Organizers for inviting me once again to attend this terrific meeting. I have to confess, when I got the invitation, that part of the motivation about coming was to escape another Canadian winter. That didn't work out so well. But anyway, I'm really glad to be here to talk about what I think is an ongoing, enduring problem in cancer research and experimental therapeutics that's relevant not only to this session, but later today, the experimental therapeutic session. And what I'm referring to is the use of preclinical models to test anti-cancer drugs, usually in mice, what I'm referring to, where often the outcome is over-prediction. One sees maybe a stunning, encouraging result in mice, it goes forward into clinical trial development, and then not only doesn't show a lesser result, but actually a complete failure. Now, in relationship to my presentation, I'll start with a disclosure and begin with some of the approaches, the major approaches that are being used currently to try and address this problem of improving the clinical relevance and the predictive potential of preclinical mouse models for cancer treatment and research. Well, the major approaches these days, first of all, are using genetically engineered mouse models of spontaneous cancer, or so-called GEMs. They're on the ascendancy still. Coming up very fast, though, are the use of patient-derived xenografts of fresh tumor tissue grown in immune-suppressed mice. I'm going to be talking about a third approach. Minor, but I think major in terms of potential, and it could be complementary to the other models that I've shown here. And what I'm referring to is actually the development preclinically of adjuvant and metastatic therapy models. In other words, treating mice with disseminated metastatic disease. It's actually amazing to me as a tumor biologist, as a preclinical researcher, how seldom this has actually been modeled in mice over the last half century. So what's the rationale? To use models of advanced or for that matter, early stage metastatic disease for drug therapy testing? Well, first, the vast majority of preclinical therapy studies undertaken over the last 50 years have either involved transplanted primary tumors or spontaneous primary tumors, usually nowadays in genetically engineered mouse models of cancer, or if metastasis studies have been done, often low-volume metastatic disease models, not advanced metastatic disease. And in contrast, as we all know, patients in all phase 1 and phase 2 trials, and in most phase 3 trials, usually have advanced systemic metastatic disease, bad disease, much more difficult to treat successfully. So we've been arguing that perhaps successful outcomes using new models of advanced metastatic disease will improve their predictive clinical potential. And by that I mean not exactly mimicking the result that you get in these models, but at least getting or not obtaining a false positive. And I think the same arguments may apply to adjuvant therapy of early stage microscopic disease, and I'll address that near the end of my presentation. Now, we've developed a number of models using human tumor cell lines, not patient-derived xenografts, which we're beginning to study now, developing these sorts of models, mainly for advanced spontaneous metastatic disease. And they involve melanoma, ovarian, renal, hepatocellular carcinoma, and colorectal carcinoma. But our main efforts continue to be in the area of breast cancer. Now, the way we do this is as follows. A typical approach would be to take an established cell line, like the triple-negative MDA MB231 cell line, inject it into the mammary fat pads of mice. In other words, do an orthotopic transplantation that promotes metastatic disease. Next step would be to resect that primary tumor. In other words, do a mastectomy to allow the mice to survive long enough for seeded micrometastases to grow into overt metastases. And that can often take 4 to 6 months to actually see these overt metastases. You then can recover those mets, make cell lines from them, and then repeat the process one more time of orthotopic transplantation, surgical resection, And with the second selection, the disease becomes more aggressive from a metastatic point of view. You can recover individual nodules, make cell lines out of those nodules, for example, this line called LM24, a highly aggressive, spontaneously metastatic variant, which now we will use for a therapy experiment by, again, doing orthotopic implantation, surgical resection, waiting until the mice get metastatic disease, usually in the lungs, but often extrapulmonary mets can manifest themselves as well in sites like the liver, lymph nodes, sometimes recurrence at the mammary fat pad site as well. So it's at this point that we will initiate the therapy. And the expectation is that a lot of things that might work traditionally in a primary tumor therapy model will not necessarily work as well or at all in the metastatic setting, but we're looking for exceptions. Well, to try and validate this approach, what we've done is to look at the impact of antiangiogenic agents. That's one of my major areas of study, and as many of you know, this is a class of drug that has not done particularly well in breast cancer. So why is that? Because it seemed to do well, again, preclinically. That's one of the reasons why this class of drug went forward into extensive clinical trial development. So here's a paper that was published in 2003, a decade ago, by a group at Sugen, where they looked at a drug called SU11248, better known nowadays as sunitinib or Sutent. It's an oral antiangiogenic tyrosine kinase inhibitor, targets VEGF receptors, PDGF receptors, c-KIT, and so forth. And on the basis of this preclinical study, the authors concluded that these results demonstrate that the drug is effective in preclinical breast cancer models and suggest that it may be useful in the treatment of breast cancer in the clinic. So what were the results? Well, the results were mainly dealing with the treatment of primary established breast cancers in 3 different models. And the first model was a transgenic model. And you can see here that when the drug was given during this period of time here, the drug actually showed activity. When the treatment was stopped, the tumor started to regrow. When the drug was readministered, then another response was achieved. So the drug seemed to show activity in this model. And a second model dealt with rat carcinomas induced chemically. And again, depending on the dose of the drug, one could even get regression of established primary tumors or something resembling stasis. So in the second model, the therapy worked. The third model involved human breast cancer cell lines injected into mice combined with chemotherapy. And again, success. And the major success was, for example, combining sunitinib, in this case with docetaxel, where you see the synergistic-like prolonged response in tumor control and prolonged survival as shown here. So these are some of the results that provided a rationale for this drug moving forward into clinical trial development. And there were no less than 4 trials done with this drug in breast cancer, 2 in the first line, 2 in the second line. 3 of them involved addition of chemotherapy, either docetaxel, capecitabine, or paclitaxel. And as many of you know, all of these trials failed. So one of the things that we have done recently is to go back and mimic what was done 10 years ago, but with the addition of modeling metastatic disease. And we did so partly for another reason, because this is actually part of a much larger problem, a mysterious problem to me, and that is the failure consistently of small molecule tyrosine kinase inhibitors to improve the efficacy of standard chemotherapy regimens. Not just anti-angiogenic tyrosine kinase inhibitors, but others as well, such as EGFR targeting TKIs. So this has been seen, for example, in lung cancer and colorectal cancer. It doesn't seem to matter what the chemotherapy backbone is. It doesn't seem to matter what the anti-angiogenic TKIs. All these trials were essentially failure, and there's been no approval yet of this type of combination. So when we go back, reproduce this kind of experiment that was done by the Sugen group a decade ago, well, when we treat primary tumors growing in the mammary fat pads of mice shown on the left-hand side of the slide, we get a reasonably robust result and a prolongation of survival of the mice. Now, if we take another group of mice, resect that primary tumor, allow the mice to get advanced metastatic disease, this is the result that we obtain, which is a negative result. there is no increase whatsoever in median overall survival, or even, we suspect, in progression-free survival. Now, what happens if we do the same experiment, but now we add chemotherapy to the sunitinib? Well, the result remains pretty much the same. And so, for example, sunitinib and paclitaxel shown over here in this pink line. Here's the control over here. And again, no increase in any of these groups compared to the untreated control of statistical significance. So again, in a superficial way, I would say we were able to go back retrospectively, reproduce the negative trial results of a TKI of sunitinib plus chemotherapy or alone in metastatic breast cancer. What about if we substitute a TKI with an antibody? Because obviously in the first trial that was led by Kathy Miller, the E2100 trial, that showed a benefit in progression-free survival, as many of you know, of almost a half year, led to the accelerated approval of this drug in the United States, still approved here in Europe, but no longer in the United States with weekly paclitaxel. Well, now when we use an antibody that targets VEGF receptor 2, not bevacizumab, we do find a small but statistically significant increase in survival, unlike the situation with sunitinib and chemotherapy. And these results will be published in the next couple of weeks in Cancer Research. So one of the things that we've been looking at now is not just to reproduce negative prior clinical findings, but to see if we can develop a therapy or an approach that may actually show efficacy in the advanced metastatic disease setting. Again, the rationale being this might, and I emphasize that, have a greater probability of eventually showing some kind of positive clinical trial benefit. Where we've had some success, or our major success, is with various metronomic chemotherapy regimens used alone or in combination with a targeted therapeutic, mainly an antiangiogenic drug. And our first success involved the concurrent treatment of two different oral drugs, UFT, a 5-FU prodrug of Tegafur and Uracil, combined with cyclophosphamide, where both were given every day nonstop, beginning 20 days after surgical resection of the primary tumor. So again, we're treating metastatic disease and looking at overall survival as an endpoint. And this pilot experiment showed a rather remarkable effect of the two-drug combination compared to either drug alone. On the right-hand side of the slide is shown a repeat of the same two-drug combination. We used UFT in this study in part because in retrospect, there have been trials of this drug, mainly in Japan, involving daily administration using non-toxic doses for the drug for up to 2 years in the adjuvant setting. For example, in lung cancer, shown in this slide, where a benefit was seen in a subset of these early-stage post-surgical patients of adenocarcinoma of the lung. And something similar has been seen in breast cancer as well, where the UFT 2-year daily protocol was compared to the classic CMF regimen. Equivalence in survival was seen, but the oral regimen was found to be less toxic. So the results that we obtained had, I think, an impact in stimulating this trial by Marco Colleoni and his colleagues. This is a small non-randomized phase 2 trials evaluating cyclophosphamide, not UFT, but capecitabine combined with bevacizumab in the advanced metastatic breast cancer setting. And that result has now moved forward into phase 3 clinical trial testing in Switzerland. Right now, as best I can determine, there are about 9 or 10 randomized phase 3 trials involving what we might call metronomic chemotherapy. Here are 3 on the top involving breast cancer, and the 2 on the bottom involving colorectal cancer. And you can see that 3 of these trials involve the addition of a targeted agent, namely bevacizumab, the monoclonal anti-VEGF antiangiogenic antibody. Now, the reason for that combination also comes from work not only in our lab, but a number of others as well. We're testing various empiric metronomic chemotherapy regimens in models of advanced disease in mice. You get an improvement by addition of an antiangiogenic drug. This is a model actually involving advanced ovarian cancer with multifocal metastatic disease in the peritoneal cavity. And in this case, the antiangiogenic drug is sunitinib-like. It's pazopanib, not identical. It's approved for soft tissue sarcomas and for kidney cancer. And again, this is a recurring theme. The targeted agent on its own does not show efficacy in the advanced metastatic setting. The metronomic, in this case, oral daily topotecan protocol did, but the extent of that efficacy went from this to this by addition of the seemingly ineffective anti-angiogenic agent. 6 months of continuous therapy, 100% survival going out for that period of time. So we've repeated this protocol now of topotecan, and in this case, sunitinib, in the post-surgical metastatic advanced metastatic breast cancer model that we've developed. Again, results are similar in that the anti-angiogenic drug alone did not have efficacy as expected. In this case, the low-dose metronomic topotecan protocol didn't either, but the combination of the two, regardless of the 30 or 60 milligram dose of sunitinib, obviously, as shown here, had a marked ability to prolong survival of the mice. Now, one of the other interesting things about using these models that we've seen a number of times is that if we can prolong the mice that have systemic metastatic disease, in melanoma, in breast cancer, in kidney cancer, if their survival is prolonged, a fraction, sometimes a healthy fraction of those mice eventually relapse with spontaneous brain metastases. And we think this, again, is a reflection of an important clinical phenomenon. This is an example where mice with HER2-positive advanced metastatic disease treated with Herceptin relapsed with metastatic disease sometime later on. Now, I'd like to end on this question, and that is, would combining metronomic chemotherapy with targeted anti-angiogenic drugs be an effective strategy to reverse the failures of anti-angiogenic drug-based adjuvant chemotherapy regimens that have been noted thus far in phase 3 clinical trials? Now, I mention that because, as some of you or many of you know, there have been now 3 major, large, randomized trials of bevacizumab combined with standard chemotherapy that have failed. 2 in colorectal cancer, 1 now recently announced, the Beatrice trial, in triple-negative breast cancer. And we actually, some years ago, raised a red flag about the use of anti-angiogenic drugs in the adjuvant setting. This was a paper that was published in Cancer Cell, and you can see the quote down here, that our results may be pertinent to the consideration of several prominent issues in cancer therapeutics, including the use of anti-angiogenic drugs in the adjuvant setting. Now, this remains a controversial paper. There were something like 15 different commentaries and editorials written about this paper, and an accompanying one from Doug Hanahan's group in the same issue. I think the one editorial in my mind that got it right was by George Sledge and his colleague Brian Snyder when they mentioned anti-VEGF therapy. Are there clouds on the horizon? And that question was based mainly on this adjuvant study that we published in this issue of Cancer Cell. And without going into many details, basically what we did was to image the mice. So these are luciferase-tagged human metastatic breast cancer cells, that same LM24 cell line. You can see in the top panel over here the presence of tumor in the mammary fat pads in all of the mice. It's resected about 3 or 4 weeks after transplantation. No evidence of metastatic disease, overt metastatic disease, over the next few days. And if we begin therapy during that period of time, then we're doing something akin to adjuvant therapy of microscopic disease in these mice. And when we used a high dose of sunitinib for a short period of time, so that's a limitation of this particular experiment, what we actually noticed was an acceleration of metastatic disease as shown over here and reduced survival times. Now, we've repeated this experiment with lower doses of drugs as other groups have and longer treatments. We have still yet to see a benefit using these lower doses or longer-term treatment protocols in the adjuvant setting. So, major take-home points. First of all, I've tried to summarize the potential therapeutic benefits of using preclinical, in this case, breast cancer models of advanced metastatic or early-stage microscopic disease as an additional approach for drug therapy predictive testing. The promising potential of metronomic chemotherapy alone, or when combined with an antiangiogenic drug for the treatment of metastatic disease, and possibly for early stage micrometastatic disease as well. And finally, the possibility that the repeated failures of oral, in this case anti-angiogenic tyrosine kinase inhibitors, when combined with conventional chemotherapy regimens, might conceivably be reversed, at least in some cases, by using metronomic chemotherapy regimens instead. And another issue that we're trying to tackle now are the differences in outcome when treating metastatic disease on the one hand and primary tumors on the other, using, for example, anti-angiogenic drugs. And related to the theme of this meeting, what we're finding are major differences in the stroma, particularly the vasculature populating the metastases in these animals as compared to the primary tumor. Well, finally, I'd like to acknowledge a small number of dedicated people who've been involved in this work. The last two, Raquel Munoz and Eric Guerin, were actually sabbatical workers in my lab, and the others are mainly very dedicated, long-term surviving technicians in my lab. Thank you very much for your attention.